So today we will discuss about the last part of the hematological system or hematinics. So till now in the previous class we have studied about the anticoagulants. So parenteral anticoagulant and oral anticoagulant. Parenteral anticoagulant, the important is the heparin, low molecular weight heparin, fondaparinux, etc. And within the oral anticoagulant, the most important is the warfarin, which is the vitamin K antagonist, which I have seen. So from today, we will discuss first about the novel oral anticoagulants. So what is this novel oral anticoagulants? So already we have seen that warfarin or different coumarin derivatives, which are mainly used as oral anticoagulants traditionally, they are basically vitamin K antagonists. Already we have seen. They block the vitamin K epoxide reductase. Already we have seen the mechanism. So by blocking this, ultimately the cycle is broken and factor 2, 7, 9, 10, they will not be activated. But the problem of the warfarin that is very important is there is different types of the interactions. There may be drug-drug interactions, food-drug interactions. The therapeutic index of the warfarin is also very narrow. So there is more chances of the bleeding, and when the warfarin is given, the dosing is to be adjusted individually, and this adjustment is usually done by measuring the prothrombin time, and ultimately deriving from this prothrombin time is the INR, that is the international normalized ratio. And already we have seen that the INR have to be kept between a tightly controlled spectrum for the different diseases. For example, if there is deep vein thrombosis, we have to prevent this, the INR have to be kept between 2 to 3. And if the INR is greater than 3 or less than 2, either there will be more bleeding or there may be subtherapeutic effect. And already this warfarin or other oral anticoagulants are also needed to prevent the thromboembolisms in some cardiac problems like atrial fibrillation. When there is fibrillation in the atrium, there is always chances of the embolus, and that embolus may be lost elsewhere, for example in the cerebral vessels, and a stroke can happen. So to prevent the cerebrovascular accident or stroke in case of the atrial fibrillation patients, mainly we have to use the different types of the anticoagulants, the oral anticoagulants. Now already we have seen that warfarin, what I am saying, that there is problems with the warfarin, because the warfarin have to be monitored, for example every 3 days or every weekly. Otherwise there will be either increased INR or either there will be decreased INR. So this is the problem, and again there is this warfarin is metabolized by the cytochrome enzymes and different other enzymes also, that is also inhibited by different drugs or accelerated by different drugs, their metabolism. So there are very different types of the drug-drug interactions, there may be food-drug interactions, etc. So all these are drawbacks of the warfarin. Due to this drawback, the newer some anticoagulants are developed. These are known as the novel oral anticoagulants or NOACs. So novel oral anticoagulants means, novelty means this, the advantage of these novel oral anticoagulants are that the monitoring is not needed for this novel oral anticoagulant. This is the first and foremost advantage of the NOACs. So for warfarin, for the different persons in the different time period, we have to adjust the dose, different doses are given. For this novel oral anticoagulants, there is specific dose, and this specific dose is given to all the individuals. So we do not have to change the dose, and monitoring is not needed. And these novel oral anticoagulants also have very less food and drug interactions. Their therapeutic index is wide, so that there will be less chances of the bleeding. There is less problems of the different drug-drug and drug-food interactions. So this is very important questions. What are the advantages of the novel oral anticoagulants? That is, what is the novelty of these novel oral anticoagulants? So these are the advantages of the NOACs or novel oral anticoagulants. So novel oral anticoagulants, already what we are using, there are 4 types of the novel oral anticoagulants. So Dabigatran, Rivaroxaban, Edoxaban and Apixaban. These are the four novel oral anticoagulants. Dabigatran, Rivaroxaban, Edoxaban and Apixaban. Mainly these novel anticoagulants act directly inhibiting the thrombin or directly inhibiting the factor 10. So Dabigatran is a novel oral anticoagulant that directly inhibits the thrombin, direct thrombin inhibitor, oral direct thrombin inhibitor. And the other three, they are mainly directly inhibiting the factor 10. So these novel oral anticoagulants, Dabigatran, Rivaroxaban, Edoxaban and Apixaban, these are mainly approved after the 2010, 2011, 2014 like this. Mainly these are used in these cases, like if there is any deep vein thrombosis, prophylaxis or treatment, if there is any acute myocardial infarction, prophylaxis, to prevent the cerebrovascular accidents in case of the atrial fibrillation patients. In these cases, we can give a single dose of the novel oral anticoagulant. We do not need frequent monitoring, only a single dose is given, and accordingly this can be usually can be used. So now coming to the novel oral anticoagulant Dabigatran. So Dabigatran is an agent that was first approved in the 2010 and that mainly directly inhibits the thrombin. So usually the twice daily dosing is needed, but for the other three novel anticoagulants usually once daily dosing is needed and they are more commonly used nowadays. So after the novel oral anticoagulants, next thing what we have to learn about the thrombolytics. So thrombolytics or fibrinolytics. So have you heard the term thrombolytics? So this is an important drug, this group of drugs that is needed in the acute myocardial infarction. When there is ST segment elevated myocardial infarction, a patient comes with chest pain and on ECG it has been seen that the ST segment is elevated. Troponin T or troponin I, these are the biomarkers of the myocardial infarction. They will show positive. There will be increased rise of this. So ultimately, when this rise happens, we have to do this myocardial infarction patients. There are some initial treatment. Already we have read in the ischemic heart disease chapter. It has been done now about the treatment of the myocardial infarction. So initially we have to give some drugs, like we have to give the statins, we have to give the antiplatelet drugs. We will discuss about this. And after that, there are two ways. Either we have to thrombolize the clot that is blocking the coronary arteries, or the percutaneous coronary intervention. So percutaneous coronary intervention means within the cutaneous route, we have to insert a stent so that the clots will be dissolved. And this percutaneous intervention is now the gold standard for the myocardial infarction, and it has to be done in a golden period within a very short period of time. But very few facilities in our country and all of the world also, there are some percutaneous intervention facility that is known as a cath lab. So cath lab is very rare, and also there is chances that the patient will be transferred to a cath lab very early. So in this interim period, to save the patients, we have to thrombolize. Okay, so thrombolytic drugs are needed for this thrombolysis, and in different trials it has been seen that it is also life-saving. Now these thrombolytic drugs are different types of the drugs. The previous one, most commonly used and less costly, is the streptokinase. Streptokinase is a drug that is obtained from the streptococcus, it's a bacteria, and this ultimately activates the plasminogen. You know about the plasminogen system, so they are basically activates the plasminogen system so that the already formed clot that will be dissolved, that is a fibrin meshwork that will be dissolved. So but the problem of this streptokinase is there may be chances of the bleeding in the intracranial sites also happen, intracerebral or intracranial bleeding may happen, and since it is obtained from the streptococcus species, so there is always chances of the antibody formation. So we are giving a drug from the bacteria so that already there is always chances of the antibody formation, so that if the patient needs again thrombolysis after, for example, 6 months, we are using the streptokinase, it will not act. So antibody formation may happen. Next is, since again it is obtained from a bacteria, so there is chances of the febrile reaction or anaphylaxis, allergic reactions. So these are the problems of the streptokinase. That's why the newer ones are invented. For example, urokinase, that is obtained from the human urine, that is basically a tissue plasminogen activator, TPA. Tissue plasminogen activator is normally present in our plasma. We are just accelerating it. And the newest one which we are using now in the cath labs are the Alteplase, Retiplase and Tenecteplase. Alteplase, Retiplase and Tenecteplase. These three drugs are basically can be given either by IV infusion and also by direct IV shot. So a patient comes with myocardial infarction, we are giving some initial drugs like statins, we are giving the Clopidogrel, we are giving the other drugs, and then we are doing the thrombolysis. Tenecteplase can be given just a bolus shot, and this shot is given according to the weight. So usually according to the weight a single dose is given, and Retiplase and Alteplase slightly that needed a slightly more infusion with a long time. So ultimately that will lyse the clots. So fibrinolytic drug. So already we have, these are the already I have already given the novel oral anticoagulant. So these are the indications already we have discussed to lower the risk of stroke and embolism. So when arterial fibrillation, so fibrillating arteria, so ultimately that leads to thrombus or embolus, and ultimately that can leads to the cerebral blood vessels, and ultimately CVA can happen. So did arterial fibrillation patients, if we want to stop the CVA, we can use the novel oral anticoagulants. Deep vein thrombosis prophylaxis, treatment of the deep vein thrombosis and pulmonary embolism, and to reduce the risk of recurring deep vein thrombosis and pulmonary embolism after initial therapy. So Dabigatran already we have discussed. So basically it is given twice daily. Direct thrombin inhibitor, oral bioavailability is low, the anticoagulant effect is consistent, and no laboratory monitoring is needed. Rivaroxaban and Edoxaban is very commonly used now. Rivaroxaban is a orally active direct inhibitor of the factor 10A, already we have discussed, just a recapitulation. Anticoagulant effect develops within 3 to 4 hours of ingestion and lasts for 24 hours. So that is also a utility, because when we are using the warfarin, I have given about the heparin bridging, because the warfarin needs approximately 5 to 10 days for its effect to manifest. So within this time period we have to use the parenteral anticoagulant like heparin. So this is known as the heparin bridging. But for this novel oral anticoagulants, the onset and offset of the action is very rapid. That's why we don't need any heparin bridging. Instantly we can use it, and instantly when there is operation or when do not we need any anticoagulant, we can stop this. Okay. Okay. So already we have discussed this, and then after the thrombolytics, another is the anti-fibrinolytic drug. So fibrinolytic or thrombolytic already we have discussed. The example is the streptokinase, urokinase, Alteplase, Retiplase and Tenecteplase, and another group of the drug is the anti-fibrinolytic. So basically these are used when there is increased bleeding like that of the coagulants. The example is the epsilon aminocaproic acid and the tranexamic acid, of which the tranexamic acid is very commonly used nowadays. Tranexamic acid. So when there is some bleeding after the pregnancy, so when there is bleeding after the tooth extraction, or if there is some hemorrhagic disease, in those cases like that of the coagulants, we can use the tranexamic acid. After that, another important thing, the most important thing is the antiplatelet drug. It's a broad group. So antiplatelet drug is basically blocking the platelet adhesion and activation. And the most important antiplatelet drug is the aspirin. So already you have read about the aspirin in the NSAIDs. So what does the aspirin mainly does? Aspirin mainly causes the prostaglandin synthesis pathway. They are blocking the cyclooxygenase. Prostaglandin synthesis pathway is blocked. Now there are COX-1 and COX-2. You have already know. So COX-1 is basically needed for the thromboxane A2 synthesis, and the COX-2 is mainly needed for the prostacyclin I2 synthesis. So when this aspirin is given in a low doses, for example 75 to 150 or 325 milligram, basically that preferentially blocks the COX-1, but it does not have or very little effect on the COX-2. What is the consequence of this? When the COX-1 is blocked, thromboxane A2 synthesis is blocked, And this thromboxane A2 is a prothrombotic molecule. So basically that causes the thrombosis. So when we are using this, thromboxane A2 synthesis becomes very less, and this thromboxane A2 basically causes platelet aggregation and adhesion. On the other hand, COX-2 is needed for the prostacyclin I2 synthesis. Prostacyclin I2, the action is just opposite of the thromboxane A2. So prostacyclin I2 is a vasodilatory material that ultimately inhibits the platelet aggregation and adhesion. So when we are using a low dose of the aspirin, that blocks the thromboxane A2 synthesis but does not block the prostacyclin I2 synthesis. So ultimately it leads to antiplatelet action due to blocking of the thromboxane A2, and also have vasodilatory action since there is prostacyclin I2 synthesis is going on. But when we are using aspirin in high doses, like in the NSAIDs doses, both the thromboxane A2 and as well as the prostacyclin I2, that is COX-1 and COX-2 are blocked. So this is a very common question, that why low dose aspirin is used as a antiplatelet drug but not high dose aspirin. Again, when we are using the high dose aspirin, there is more chances of the gastrointestinal bleeding. Very common. That's why it is very less used as a NSAIDs. So NSAIDs means non-steroidal anti-inflammatory drug. So anti-inflammatory or antipyretic or any drug against pain, we are using the high dose aspirin because there is more chances of the gastrointestinal hemorrhage, the bleeding. Hence we are using some other NSAIDs. So low dose aspirin mainly used as an antiplatelet drug, not the high dose aspirin. So Rivaroxaban, and these are some antidotes. Details is not required. So antidotes, so Warfarin, the antidote is the vitamin K because it is the vitamin K antagonist. And these are the newer antidote for the novel oral anticoagulants like andexanet, aripagine, edarucizumab, etc. Of which edarucizumab is available. That is needed if there is some overdose of the novel oral anticoagulants. Uses of the anticoagulants, time and again, the uses of the anticoagulants or novel oral anticoagulants are similar. Deep vein thrombosis, pulmonary embolism, myocardial infarction, unstable angina, rheumatic heart disease, stroke prevention in atrial fibrillation, cerebrovascular disease, vascular surgery, prostatic heart valve, retinal vessel thrombosis, extracorporeal circulation, hemodialysis, deep fibrillation syndrome, etc. etc. The same thing. So the anticoagulants, all the anticoagulants, parenteral anticoagulant like heparin, warfarin, novel oral anticoagulants, all these are very important. So this is the streptokinase, already we have seen. This is the plasminogen plasmin system. In the first class we have discussed. So basically when the clot is formed, we have to blast the clot, otherwise there will be problem. So streptokinase, we have discussed all this, that is the antibodies of formation occurs, there may be anaphylaxis, that is antigenic, fever, hypotension, arrhythmia can happen. It should not be used in the second time. So already there may be some patients where the repeated heart attack may happen. So we cannot use the streptokinase second time. It is obtained from the streptococci group C. Urokinase obtained from the human urine. It is a tissue plasminogen activator, purified. Similar actions more or less. Alteplase, Retiplase, Tenecteplase, the newer one, already we have discussed. So they are more specific, fibrin specific, so their actions on the other proteins are very less. That's why the adverse effects are also very less. Plasma T-half is very less. You can see 4 to 8 minutes. Short T-half, rapid onset and offset of the action. Non-antigenic, some nausea, mild hypotension, etc. can happen, but this is expensive. Retiplase is the modified form of the tissue plasminogen activator. This Alteplase, that is a longer acting and less specific for fibrin bound plasminogen, longer duration. Ultimately, when it will be longer duration, we can use once bolus dose administration. Otherwise, we have to give the longer time of infusion. That is another problem. Tenecteplase, most short acting, usually given a bolus dose, but it is costly. Genetically engineered substituted mutant of the native tissue plasminogen activator, they have the fibrin specificity is the highest, very high fibrin specificity, resistant to inhibition by other proteins that is present in the plasma like plasminogen activator inhibitor 1. So there are different other proteins that can activation inhibition. So they are resistant to inhibition by this also. They can be injected IV single bolus dose over 10 seconds, while Alteplase requires, you can see, approximately 90 minutes. That is, infusion is needed. Immediate institution can be given. So immediate there is heart attack, immediately we can give this. Risks of non-cerebral bleeding may be lower with Tenecteplase, but some cranial bleeding incidents can happen. So the problem of this, all these thrombolytics is there may be chances of the bleeding within the brain. So with these newer ones, the bleeding within the brains will be less. So uses of the fibrinolytics, main use is the acute myocardial infarction. Acute myocardial infarction main use. Apart from this, deep vein thrombosis, pulmonary embolism, peripheral arterial occlusion and stroke. So when you have asked, you will be asked about the management of the myocardial infarction, quite a common question. So first you have to write some bolus dose, some immediate drugs is to be given. For example, statin, clopidogrel, etc. These has to be given. After that, you have to give the thrombolytics, or we have to give the percutaneous coronary intervention (PCI). And what are the thrombolytics? What are the older thrombolytics like streptokinase, newer ones? What are the advantages, disadvantages? This can be asked. There are some contraindications of the fibrinolytic therapy. So there are checklists. So we cannot give all the patients with myocardial infarctions of fibrinolytic, because if there is some prior intracranial hemorrhage, history of the hemorrhage within the brain, prior intracranial hemorrhage, we should not give the thrombolytic therapy. So in these patients, we have to do the percutaneous coronary interventions, PCI. Non-structural cerebral vascular lesion. So when there are some structural cerebral vascularism like Berry aneurysm, so there will be more chances of the bleeding within the brain. Non-malignant intracranial neoplasm, the same thing, more chances of the bleeding. Ischemic stroke within 3 months. Suspected aortic dissection. Active bleeding or some bleeding diathesis like excluding the menstruation. Significant closed face trauma or facial trauma within 3 months. So these are the absolute contraindications where we should not give the thrombolytic therapy. We should use only the percutaneous coronary intervention. These are some relative contraindications. That is, we have to weigh the pros and cons about this, and again we have to use this if there is no way of the percutaneous coronary intervention. For example, uncontrolled hypertension where the systolic blood pressure is greater than 180 and diastolic blood pressure is greater than 110. So again there is more chances of the stroke, more chances of the bleeding. Traumatic or prolonged CPR, cardiopulmonary resuscitation or major surgery within 3 weeks. Again there is more chances of the bleeding. Recent, that is within 2 to 4 weeks, internal bleeding, any type of the internal bleeding. Non-compressible vascular punctures, that is there is non-compressible, that is after compression there will be bleeding is going on. For streptokinase prior exposure, already we have seen, because when there is prior exposure there is more chances of the bleeding, there is development of the antibody, the streptokinase will not act. Or prior allergic reaction to streptokinase, pregnancy, active peptic ulcer, and current use of the warfarin and INR is greater than 1.7, because there is very high risk of the bleeding. So these are the relative contraindications. So this is important, absolute and relative contraindications of the fibrinolytic. So antifibrinolytic drug already we have seen, epsilon aminocaproic acid and the tranexamic acid. So these are the drugs which inhibit the plasminogen activation and dissolution of the clot and used to check fibrinolysis associated with bleeding. So just like coagulants, it can be used. This is the IIIa, this is the first one, potent inhibitor of the fibrinolysis and can reverse states that are associated with excessive fibrinolysis. What are the primary indication of this? To counteract the effect of the fibrinolytic drugs and bleeding due to their use. So this can be used when there is more usage of the fibrinolytic drugs, we have to reverse the use of the fibrinolytic drugs. In hemophilia, when there is factor 8 or factor 9 deficiency, when there is more chances of the bleeding, it has adjunctive value for controlling the bleeding due to tooth extraction, prostatectomy, trauma, etc. So hemophilia, there is always chances of the bleeding, so you have to use the different coagulants, different antifibrinolytic drugs, etc. Hematuria, in hematuria it can cause ureteric obstruction by the unlysed clot. So therefore fibrinolysis must be established firmly before using it. What does it mean? So when there is hematuria, that is blood is coming to the urine. So here we should not use the antifibrinolytic drug beforehand, because there may be some clot formation, some clots can be dissolved, and since the ureter is very narrow, so it can be blocked. So there will be anuria, that is no urine can come. So firstly we have to cleave all the clots by giving the thrombolytics, and then we can stop the bleeding by giving the antithrombolytic drug or antifibrinolytic drug. Okay. It can cause intravascular thrombosis, and rapid IV injection results in hypotension, bradycardia, arrhythmia, etc. can happen. And all these drugs can be should be cautiously used when the kidney is compromised. Tranexamic acid, more commonly used now. This is more potent than the epsilon amino caproic acid. Mainly these are used to prevention or control of the excessive bleeding due to cardiopulmonary bypass surgery or CABG, cardiopulmonary bypass surgery when it is needed. Tonsillectomy, prosthetic surgery, tooth extraction in hemophilia. Menorrhagia, especially due to intrauterine copper device. So intrauterine copper device is a mode for the birth control that leads to more menstrual bleeding. This is known as the menorrhagia. In these cases it can be used. Recurrent epistaxis, that is the blood through the nose. Hyphema, that is the blood present within the eye due to ocular trauma. Peptic ulcer, bleeding peptic ulcer, here we can use. Main side effect is the nausea, diarrhea, thromboembolic events, disturbed color vision, allergic reaction, etc. can happen but very infrequent. So tranexamic acid very commonly used in these cases. Antiplatelet drug, so antiplatelet already we have discussed, so they are basically blocking the platelet adhesion and aggregation. So you can see the plaque when it is disrupted, so it ultimately activates and attaches with the von Willebrand factor and collagen, and platelet adhesion and selection happens. Aspirin already we have discussed about the COX-1, COX-2, thromboxane A2, etc. There is another co-aggregatory molecule is the ADP, adenosine diphosphate, and again this can be blocked by these drugs like ticlopridine, clopidogrel, prasugrel, cangrelor and ticagrelor. So they are basically blocking another pro-aggregatory molecule, this is the ADP. You can see these are the different other drugs that are under research that can block different other agents like thrombin can be blocked. GP IIb 3A activation is needed for the platelet aggregation, and this can be blocked by some injectable agents like abciximab, epitifibatide and tirofiban. Abciximab, epitifibatide and tirofiban. So we will discuss about this. So you can see this is the resting platelets, and when the platelets are activated means from the platelets different these pro-aggregatory molecules are released, and also within the blood vessels the different pro-aggregatory molecules ultimately comes. The coagulation cascade is also activated, all the coagulation factors that are activated also comes, and ultimately the platelet activation and aggregation happens. And these are the active GP IIb 3A receptors that ultimately helps the different platelets to one another. Aspirin already we have discussed. It is clear, it is very important question that why low dose aspirin acts as an antiplatelet but not high dose aspirin. We have discussed. So low dose means 75 to 150 milligram per day or 300 milligram twice weekly. So this is the low dose, and high dose means minimum 900 to 1000 milligram per day. High dose means that's in the NSAIDs regimen. So already we have discussed this. Dipyridamole is the second antiplatelet drug after the aspirin. This is a vasodilator. It inhibits the phosphodiesterase enzyme and also blocks the uptake of the adenosine to increase the platelet CAMP, which in turn potentiates the PGI2 and ultimately interferes with aggregation. So more or less they are act on different these molecules. So levels of the thromboxane A2, PGI2 are not altered, but platelet survival time is reduced by disease is normalized. So somewhat slightly different mode of action. They have little clinical significant effect when it is used alone. Usually the combination is used. It improves response to warfarin, enhance the antiplatelet action of the aspirin, and this combination may additionally lower the risk of stroke in patients with transient ischemic attacks. So when the stroke or the cerebrovascular accident is not very large, this is known as the transient ischemic attack, the small stroke you can say. So in these cases we can use the dipyridamole plus aspirin combinations, or when the warfarin is used, when it is used, it can potentiate the action of the warfarin. So again we have to monitor the action of the warfarin. Okay. Ticlopidine is another one. It alters the surface receptors on platelets and inhibits ADP as well as fibrinogen induced platelet aggregation. So ultimately all this changes how the platelet aggregation happens. The GI couple P2Y12, this is a receptor, this is a purinergic receptor where the ticlopridine as well as the next one, the clopidogrel, also acts. They mediate the adenylyl cyclase inhibition due to ADP. These are blocked irreversibly by the active metabolite of this ticlopridine. So this CAMP, they are mainly blocked, and as a result activation of the platelet is interfered. There is no effect on the platelet thromboxane A2, but bleeding time is prolonged and platelet survival is increased. It can also be combined with the aspirin, low dose aspirin. It has markedly lower incidence of the wrist stenosis after the percutaneous coronary intervention and stent thrombosis. So when we are using the stent, percutaneous coronary intervention, always there is chances of the, again the problem, the blockage of the coronary arteries. So we have to continuously use these agents. These antiplatelet drugs are usually given lifelong so that there will be no blockage again. And according to the patient characteristics, we have to use the combination of the drugs. Because of its potential for serious adverse reaction, what are the adverse reactions like bleeding, neutropenia, neutrophil count can fall, thrombocytopenia, hemolysis and jaundice. Now this ticlopidine is lesser used nowadays because it is very much potent. That's why this is the previous one, lesser used now. The clopidogrel is basically a congener of the ticlopidine, and you can see this is very commonly used nowadays. So low dose aspirin and clopidogrel, these two antiplatelet drugs are very commonly used. This has to be given in a loading dose when a patient comes with myocardial infarction, and this is usually used in different types of the ischemic heart disease or when the patient already have history of the myocardial infarction. In all these cases, we have to use the aspirin as well as or the clopidogrel. So it is a newer and more potent congener of the ticlopidine. Mechanism of action is similar, that is, this acts on the purinergic receptor P2Y12. By acting on these purinergic receptors, they ultimately blocks the cyclic AMP, and ultimately the ADP that is formed from this cyclic CAMP activated, this ADP formation is blocked, and this ADP is a pro-aggregatory molecule that is needed for the platelet aggregation. So remember, this all acts on the P2Y12 purinergic receptor, clopidogrel and ticlopidine. Ticlopidine is the previous ones, but they have different types of the adverse effects. That's why the clopidogrel is more commonly used. This is safer and better tolerated. Combination of the clopidogrel and aspirin is synergistic in preventing the ischemic episodes and is utilized for checking wrist stenosis of the stented coronaries. So all these cases, if there is some ischemia, ischemic heart disease, ischemic episodes, if there is myocardial infarction, history of the myocardial infarction, or the myocardial infarction has been treated with the stenting, in all these cases we have to use this for the long period of time. Slow acting drug, antiplatelet action takes about 4 hours to start and develop over days. So usually it takes time. Slowly activated in the liver by cytochrome 2C19, exhibits genetic polymorphism. That means the clopidogrel is not active similarly in different individuals. So there may be less action or more action in some individuals. This is known as the genetic polymorphism. High inter-individual variability has been observed due to this. The most important adverse effect is bleeding. All of this, the most important adverse effect is the bleeding. Prasugrel is the newest one, latest, most potent and faster acting P2Y12 purinergic receptor blocker, greater and more predictable inhibition of the ADP induced platelet aggregation. That is, it is the potency is more, the mechanism of action of ticlopidine, clopidogrel and prasugrel, these three are similar. Okay. Cytochrome 2C19 is involved in activation of the prasugrel. Also, genetic polymorphism related decrease in response or interference has not been prominent. That is, the genetic polymorphism is less with prasugrel, particularly suitable for use in the ST segment elevated myocardial infarction. Significantly higher rates of the fatal and life-threatening bleeding has been observed by recent studies. That's why even if prasugrel is the most potent purinergic receptor blocker, but the prasugrel is again usage is lesser than that of the clopidogrel. Nonetheless, prasugrel is also used now. Patients with a history of the pulse stroke or the transient ischemic attack are a particularly high risk of bleeding. It is contraindicated in those with a history of the cerebrovascular disease. Okay. So remember ticlopidin, prasugrel as well as the clopidogrel. These three acts by blocking the purinergic receptor P2Y12, and these purinergic receptors are used for activation of the ADP, and this ADP is needed for the platelet aggregation. Ticlopidin and prasugrel, there are more adverse effect, that's why lesser use now. Clopidogrel is more used now. And usually for the first few months after the stenting, the combination of the low dose aspirin and clopidogrel is used, and after that usually a single antiplatelet is continued, usually for lifelong. Silostazole. Silostazole is another vasodilatory molecule that inhibits the phosphodiesterase type 3. Phosphodiesterase type 3, ultimately that also prevents the degradation of the cyclic AMP, more or less similar mechanism. Increased levels of the CMP in platelets and vascular tissues, and this increase in CMP and the vasculature ultimately prevents the platelet aggregation and promotes vasodilatation of the blood vessels. It favorably alters the lipid profile, and they are approved for the reduction of the symptoms of the intermittent claudication. So basically this is needed in the peripheral vascular disease. So previous ones are mainly used in some cardiovascular disease or the cerebrovascular disease. Silostazole is used in the peripheral vascular disease. Intermittent claudication means a patient walks some distance and there will be severe pain in the legs due to vasoconstriction in the peripheral vessels. This is known as the claudication. Intermittently this claudication happens due to the blockade of the peripheral vessels like that of the coronary vessels in the heart. So this silostazole is mainly used to relieve this intermittent claudication in peripheral vascular disease because it has vasodilatory property by inhibiting the phosphodiesterase molecule, increasing the CMP and vasodilatation of the peripheral blood vessels, mainly in the legs. Okay. Side effects: diarrhea, abnormal stool, dyspepsia, etc. happen. Details is not required. Already we have discussed the same thing. So you can see that from the membrane phospholipids, the arachidonic acid metabolites are formed, prostaglandin synthesis pathway. They are low dose aspirin preferentially blocks the cyclooxygenase 1. Ultimately the thromboxane A2 synthesis is decreased. Thromboxane A2 is a pro-aggregatory molecule, so ultimately there will be antiplatelet action. And here ticlopidin, clopidogrel, prasugrel and also ticagrelor will come that inhibit the ADP mediated platelet aggregation, and this ADP mediated platelet aggregation happens by blocking the purinergic receptors, mostly the P2Y12 receptors. This is the platelet phase, already we have discussed. Now coming to the GP2B3A receptor antagonist. So GP2B3A is another receptor that is also needed for the platelet adhesion and aggregation. So there are three agents that is under this group: Apixaban, apitifibatide and tirofiban. There are three drugs. These are the GP2B3A inhibitor. Now coming, this is the platelet phase. We have discussed, so this GP2B3A, you can see this GP1B and this is the GP2B3A, this molecule. This GP2B3A of one platelet and GP2B3A of another platelet, they are attached to one another by means of the fibrinogen molecule. You can see this is the fibrinogen molecule. Okay. And these are the other agents, the ADP, the collagen, the thromboxane A2. These are the other co-aggregatory molecules that is needed for the platelet phase, platelet activation. So apixaban, apitifibatide and tirofiban, they blocks this GP2B3A so that there will be no fibrinogen bridge between these two GP2B3A of two platelets. So ultimately this is the mechanism of action. Apixaban, that means it's a monoclonal antibody. That's why this is also costly. It is a FAB fragment of the chimeric monoclonal antibody against the GP2B3A molecule. It is relatively non-specific. It binds to the vitronectin receptors on the platelets, vascular endothelial cells and smooth muscle cells also. It can be given with aspirin and heparin. Mainly these are all used during the percutaneous coronary intervention, that is the stenting. During the stenting, we should use the different types of the GP2B3A receptor antagonists. These are all given parenterally. Okay, it markedly reduces the incidence of the risk stenosis. That is, again, stenosis will not happen, subsequent myocardial infarction and death. Non-antigenic, the main risk is the hemorrhage and thrombocytopenia. It should not be used in the second time since risks of the thrombocytopenia can happen. Constipation, ileus, arrhythmia, etc. can also happen. Apixaban is very expensive. Apixaban is a synthetic cyclic peptide that selectively binds to the platelet surface GP IIb receptor and inhibits platelet aggregation. Similarly, its plasma T-half 2.5 hours is longer than that of the Apixaban. Platelet inhibition reverses in a shorter time and it quickly dissociates from the receptor. That's why the bleeding chances is the less. Bleeding and thrombocytopenia are the major adverse effect, but less than that of the Apixaban. Tirofiban is a non-peptide specific GP IIb receptor antagonist. Plasma T-half is 2 hours, dissociates rapidly from the receptor, used to treat acute coronary syndrome for stenting, angioplasty, coronary intervention. So all these GP IIb receptors are mainly used in coronary interventions. That is when we are using some percutaneous coronary interventions or some angioplasty or angiography is given. These are some newer antiplatelet drugs like Cangrelor and Ticagrelor. Cangrelor is an adenosine analog, binds reversibly to P2Y12, similar to that of the Clopidogrel, inhibits its activity, but the T-half is very short, 3 to 6 minutes, given IV as a bolus. It can be given as a bolus followed by infusion. When stopped, platelet function recovers within 60 minutes. Ticagrelor can be given orally active, reversible inhibitor of the P2Y12, more rapid onset and offset of the action than Clopidogrel, also produces greater and more predictable inhibition of the ADP-induced platelet aggregation. This is the first new antiplatelet drug to demonstrate a reduction in the cardiovascular death compared with Clopidogrel in patients with acute coronary syndrome. So, different trials are ongoing and it has been seen that after the Clopidogrel, this Ticagrelor, when it is given, they decrease the cardiovascular death after the myocardial infarction when it is given. So, Cangrelor, Ticagrelor, these are the newer ones. So, what these antiplatelet drugs are used? Uses of the antiplatelet drugs. The aim of this antiplatelet drug is to prevent the intravascular thrombosis and embolization with minimal risk of hemorrhage. This is the aim. So, already we have discussed, mainly we are using the different types of the coronary artery disease, acute coronary syndromes, unstable angina, NSTEMI and STEMI, that is the ST segment elevated myocardial infarction, and also in non-ST segment elevated myocardial infarction, cerebrovascular disease like different types of the strokes, prostatic heart valves, arteriovenous shunts, venous thromboembolism and peripheral vascular disease. So these are the areas where we should use the antiplatelet drug. Arekta slide ache ami bolchi. So how we have to use the antiplatelet drug. So this is important. So when a patient comes with some ischemic heart disease, so in these cases we have to use the antiplatelet drug. When a patient comes with some history of the acute myocardial infarction, we should start with some combination of the antiplatelet drug. Usually, most commonly in our country, we are using the low dose aspirin and clopidogrel combinations. Okay, and after some 3 to 6 months, this low dose aspirin or clopidogrel, one is stopped and another is usually continued for the lifelong. Similarly, this different types of the anticoagulants are also used, novel oral anticoagulants, mainly in case of the atrial fibrillation patient. This is another cardiac conditions where there is more chances of the stroke. So in these cases again we have to use usually lifelong. So this is in a nutshell about all these drugs, all these antiplatelet drugs. So you can see the aspirin. What are the adverse effects? So aspirin, the most common adverse effect is the bleeding, mainly in the gastrointestinal side. At with increased dose there will be more bleeding. Apart from this, there may be angioedema. With aspirin there may be more chances of the bronchospasm, and there is one term like aspirin induced asthma. You have probably heard. So aspirin induced asthma is very common in our country also. So bronchospasm can happen, Ray's syndrome, Stevens-Johnson syndrome can also happen. Okay. So drug interactions etc. can happen. So in all these cases, we have to monitor by the complete blood count and the liver function test. Silastazole is mainly used in the peripheral vascular disease to prevent the intermittent claudication. Bleeding, gastrointestinal disturbances, headache, peripheral edema, Stevens-Johnson syndrome all can happen. Clopidogrel very commonly used, again the bleeding and Stevens-Johnson syndrome. So Stevens-Johnson syndrome very commonly associated with these antiplatelet drugs. Basically, this is a skin disorder. This is an anaphylactic or allergic disorder where the skin is peeled off from the body. So this can happen. Dipyridamole, already we have seen bleeding, dizziness, gastrointestinal discomfort, rash, etc. can happen. Prasugrel, again the similar type of the adverse effect profile. Ticagrelor is the newer ones. Again the bleeding, dyspnea, headache, etc. can happen. So these are usually all given the orally. And the injectable is the GP IIb receptor antagonist, Apixaban, Apitifibatide and Tirofiban. Adverse effects are hypotension, nausea, vomiting and thrombocytopenia. And here we have to monitor by giving by APTT, platelet count, thrombin time, etc. So this is all about the hematologic system. So within the hematologic system, this is very important. You have to read within this anticoagulants, heparin, warfarin, we have to read everything about the heparin and warfarin. The questions can come from all sides. For example, what are the indications of the anticoagulants? Why low molecular weight heparin is preferred over the unfractionated heparin? What are the advantages of the low molecular weight heparin? And then warfarin, what are the problems of the warfarin or what are the mechanism of action of the warfarin? Then novel oral anticoagulants, it can come as a short note. What are the advantages of the novel oral anticoagulants? What are the novel oral anticoagulants? Within the thrombolytics, it can come as a short note, or individually streptokinase or the newer ones can come as a short note. What are the advantages and disadvantages of the streptokinase? This is a very commonly asked question. Advantage, it is cheaper, and disadvantage, there are different types of the disadvantage. Where these thrombolytics are used, anti-fibrinolytic drug like tranexamic, epsilon amino caproic acid and tranexamic acid, this can come as a short note where it is used. Antiplatelet drug, within the antiplatelet drug, what it is used, the aspirin, everything about the aspirin in the NSAIDs chapter as well as here, why the low dose aspirin is needed, etc., etc. All these are important. And what are the other drugs like clopidogrel? Clopidogrel can itself come as a short note. And what are the uses of the antiplatelet drugs? And within the coagulants chapter also, coagulants can come as a short note. Vitamin K can come as a short note. What are the usage of the vitamin K? And apart from the other coagulants, ethamsilate is an important, that can come also as a short note. And within this coagulants, anticoagulants, antiplatelet, different types of the thrombolytics, all these can come. Different name of the drugs is very important for the viva also.